I'd like to now invite all of our speakers from session one to share their camera and unmute their microphones. We'll be hosting a panel discussion, and I'd like to start the panel discussion. We have some very excellent questions that have been posed both in the Q&A box as well as the chat box. But we'll start the panel discussion by posing a question to our audience. And I think this will cover a lot of the questions that were posed. So this is the case of Dr. Delays. A 30-year-old male was recently diagnosed with eosinophilic esophagitis. Based on symptoms, endoscopy findings, and histologic findings, there was no stricture noted on his initial endoscopy, and so dilation was not performed. He was started on swallowed fluticasone twice a day. He returns for follow-up 3 months later, and he says that his solid food dysphagia is improved, but it's still persistent, and he also has intermittent chest pain. You can see the images from his follow-up upper endoscopy, and his biopsies show that there's persistent eosinophilia. So for our audience members, we will now post a poll where we would pose whether you perform esophageal dilation at this point when you scope this patient, stop the fluticasone and start a different oral medication, assess the patient's adherence to his medication, talk about any potential difficulties or barriers that he's having in taking it, or have him continue the fluticasone and send him to a GI dietitian. So we'll take a few moments to garner responses from the audience. Curious to see how people would proceed with this particular patient. And as we're doing so, Dr. DeLay, if you could start talking about just your approach to biopsies in EOE patients. We had a question about exactly how many bites or how many biopsies are appropriate, and which sites you really suggest patients get biopsied. This question from Dr. Springer, Rocky Mountain GI. And then also how you group those biopsies. If this is sort of a more diffuse process, do you group them in a proximal and distal jar, or do you group them all together and just ensure adequate sampling of the esophagus?
Yeah, so guidelines tell us that we should be taking 2 to 4 biopsies in both the proximal and distal esophagus. That's just to increase the yield, basically, is the determination of location in the esophagus. But we should also be taking targeted biopsies. As I discussed earlier, anytime you see furrows or exudates, really those areas should be targeted as well to increase that yield. You'll never go wrong with more biopsies. Data show that if you approach 6 to 9 biopsies, your diagnostic sensitivity is about 100%. And in terms of grouping, we typically actually put all of the biopsies in one jar because we know that where the majority of the eosinophils are don't really discriminate between EOE or GERD or other disease processes. It's all limited to the esophagus and EOE. So we put them all in one jar.
Gotcha. So let's see what our audience members would do for this patient. Okay. So it looks like a large majority of folks would really spend the time to talk to the patient about the issues that they may be having with their fluticasone. Dr. DeLay, what would you do?
So I agree, and I don't think there are wrong answers in terms of the answer for this question. I think because we want to be thinking about both inflammation and the remodeling, the tissue remodeling from the fibrostenosis from years of disease, I actually would probably start with dilating this patient, because even if the inflammation is controlled, chances are that he probably does have some remodeling that's contributing to his symptoms, that fibrosis, the transmural process. So I would probably do both the esophageal dilation and then also assess the patient's adherence. Fluticasone in particular seems to be troublesome from some patients in terms of having to swallow instead of inhale. And then it's never a bad idea actually to just send to, if you have the resources, your GI dietitian to discuss the diets, to learn more about it in case down the road they would like to switch therapy, which is completely appropriate.
Great. And speaking of medications, do you ever offer these patients oral steroids, prednisone?
So data show that oral steroids are just as effective as topical steroids, potentially a little bit more than fluticasone in a pediatric population. But the systemic side effects of oral steroids probably don't outweigh the benefits that you might get from them. And so we never typically switch to oral steroids unless it's actually severe disease that haven't responded to any other treatment options.
Gotcha. And then one final question, when you do send your patients to the dietitian, what's sort of the program that your dietitian usually recommends for these patients?
Yeah, so we have a wonderful dietitian, Sarah Funk, who we work closely with, and we typically start the 6-food elimination diet, or at least start in that realm, because it often progresses to the 4-food elimination diet quickly, eliminating those tree nuts and seafood. So I've started with that, although the 2-4-6 approach is pretty palatable, actually, and I'm sure for a lot of patients too, so might be switching to that moving forward.
I see. So I do want to give other panelists a chance to discuss. Dr. Kao, there was a question that came up regarding the approach to biopsies for celiac patients. Can you talk about how you approach biopsying, how many bites you take exactly? I certainly admit that I do not take one piece per pass. Where do you biopsy and how do you separate jars, if at all?
So I think the kind of the approach to the biopsies has been fairly well set out. And one thing to remember is that celiac, the kind of enteropathy associated with celiac disease can be quite patchy. And so primary site of biopsy remains the second portion of the duodenum because it is kind of the most accessible. Certainly, if you're farther down in the small intestine, you can continue to increase yield. But so what I would recommend for a routine EGD is to take 4 bites at various locations, not all next to each other. Put those bites from the second portion of the duodenum in one jar, and you're really supposed to separate the bulb biopsies in a second jar. I don't think most people do that. I don't think most people at the university do that anyway, but that's the recommendation.
Yeah, perhaps a ripe quality improvement project for our trainees tuning in.
Yes, that's right.
Great, thank you so much. This is a question for Dr. Reveley and maybe Dr. Gumidiala in conjunction. Dr. Reveley, you talked about the substantial impact that fecal incontinence can have on patients' quality of life. Can you talk about how you offer various kind of, in addition to the medical therapies and devices that you talked about, but how you talk with them about coping and, sort of strategies. And then perhaps Dr. Gumidiala can chat about what she may be able to offer these patients.
Thanks, Ronnie. I think for many people, fecal incontinence has been going on for quite some time. It's an embarrassing event, and I think it takes a long time for somebody to get the courage to raise the issue with their primary care physician, and much less go on and talk about it to a specialist. The first thing that I do is I reassure the patient that this is a real problem and that we're going to look at multiple different aspects, psychosocial as well as the testing that's involved, to try to come up with a treatment plan that can improve their quality of life. I use the Cleveland Clinic Fecal Incontinence Score, the modified version, which really is a 5-question score that rates severity and interference with activities of daily living. Or is it liquid, solid incontinence? And I use that prior to instituting any treatment approach. And at follow-up, we review these symptom scores with the patients and see if we can actually chart objective progress toward the endpoint. Now, I will point out the retraining and the other things that we do, you really need to ask the patient up front, what is their goal? What is their goal for therapy? If they're having daily seepage and I can intervene and they come back 6 months later and they say, I've only had 1 accident in the past month, and to them, that's their definition of cure, then I've been successful. If, on the other hand, their goal was to be completely dry and completely continent under all circumstances, we have to kind of couch that in realistic terms as to where we might be able to get with a concerted effort. When we do retraining, we only do it in the office every week or 2. That does not do the job. Patients go home and have a prescribed exercise program that they do virtually every time that they go to urinate or eliminate their bowels throughout the day. So it's a real lot of work on the patient's part as well. Realistic goals over time. And I don't know if Amitha would add to that, but she worked with the top of the brain to help them get better.
Yeah, Dr. Reveley, I was going to add to that just to say that I think it's important to work together with providers. So, you know, if you're recommending some exercises that they practice at home, I think one thing that I'd be able to offer those patients is to help address any barriers that come up to engaging in those exercises regularly. And then the other part too is, as you said, it can be really embarrassing to talk about some of the symptoms that they're experiencing, and they might have a lot of fears related to getting back to activities that they were doing before. And so I think some of that cognitive behavioral work can be used there as well to help them address and overcome some of those anxieties and fears that come up with this condition in particular.
Yeah, some of these patients become housebound. I use the Imodium AD preemptively just so they can get out and go in public for 4 hours at a time. And these are often patients that have been confined to the house because of concern of having an accident in the public setting.
Yeah. Well, I do want to make sure we keep our conference moving on time. It is time for our break. I wanted to again acknowledge our exhibitors for their support. If you look at the chat box now, you will see that Christy has pushed out a link to our virtual exhibit hall. Please check out the latest and greatest from our sponsors during this break. And again, if you have any questions, I know Christy's been manning the chat box very carefully. And so any issues about CME, CNE, or otherwise, please shout out to us through the chat box or via email. We will all reconvene at 10 a.m. sharp. So please rejoin this webinar at 10 a.m. where we will start session 2, which is hot topics in hepatology. Thank you, everyone.